Dr. Nnaji served as secretary of our Noble Association from the year 2016 to 2018, and is a current serving Southeastern NSA Zonal Coordinator. So we are privileged to have him with us this evening, talking to us. And Dr. Nnaji has 40 minutes to present his topic. And thereafter, we'll take the second lecture. At the dot of 30 minutes, I will give him a signal so that he can work on the timing to ensure that we keep strictly to time. So the floor is open to you, Dr. Nnaji. We are glad to have you present the lecture that you are taking today, talking about oxygen transport. So you have the floor. Thank you so much.
Thank you, Dr. Good evening, my teachers, my chiefs, and my colleagues. I'll be taking you through the lecture on physiology of oxygen transport. Oxygen, we are all aware that is a colorless, odorless, tasteless gas that is essential to living organism. It is very vital for any functioning cell in the body. And for this to be possible, oxygen needs to be transported from the atmospheric air to the mitochondria, where it will be used for aerobic respiration. From practice, we've come to understand that oxygen is the most commonly administered drug in anesthesia and critical care medicine. And the main aim of giving a patient oxygen is actually to restore the tissue oxygen tension towards normal. And as a result of that, we use oxygen to aid resuscitation, provide life support for artificially ventilated patients, and also support the cardiovascular system. Oxygen appeared in our planet about 2 billion years ago by accumulating from photosynthesis of blue algae. But the credit of discovering oxygen scientifically will be accrued to 3 scientists: Joseph Priestley in 1774, Carl Wilhelm in 1777, and Frenchman Antoine Lavoisier. The first cylinder for storing oxygen was actually developed in 1868, and as a result of that, it facilitated the delivery of general anesthesia or conduct of general anesthesia. Yes, over time this has been modified. But oxygen was actually first made in its liquid form by Polish scientists Zygmunt Robliski and Karol Olszewski in 1883. But the use of oxygen for critical care medicine, the credit was given to George Ozapo in 1885, who actually used oxygen to manage critically ill patients with pneumonia. But in 1895, oxygen was made commercially available by German engineer and British engineer Carvon Linde and William Hobson. Down to 1907, the aerobic tubing was developed, and this has been modified to modern time as NASA catheter to be used to deliver oxygen. Whereas John Scott Held in the same year also developed modern day oxygen mask and pressurized oxygen tank. Over time, down to 1970, the use of oxygen in managing patients was revolutionized by invention of pulse oximeter by Takwa Ayadi, a Japanese engineer, and that has made the use of oxygen very, very simple in clinical medicine. But in 1970, still the same 1970, oxygen concentrator was invented. What are the properties of oxygen? It's tasteless, it's odorless. And not just only that, it comprises about 21% of atmospheric gas with a melting point of minus 218. Critical temperature is minus 118.6 degrees centigrade. Oxygen has specific gravity of 1.1 for the liquid oxygen and 1.4 for gaseous oxygen. How do we produce oxygen and how do we supply it or get it down to the end users? Naturally, oxygen is produced from plants when they involve in photosynthesis. So oxygen is released to the atmosphere as a waste products of this reaction. Whereas commercially, we can produce oxygen by fractional distillation, whereby oxygen is gradually separated from air in order to concentrate it to about 99.5% or 99.8%. But in Nigeria, most of the oxygen plant produces like 7% oxygen with 3% impurity. This produced oxygen, about 80 to 90% of them are distributed to the end users or got into the end user through a gas pipeline from a nearby air separation plant. And for it to move through this pipeline, it's compressed to the pressure of about 500 per square inch through a pipe that is about 10 to 30 centimeters in diameter. Sometimes oxygen is also gotten to the end user through insulated tank trailers or rail tankers in the form of liquefied oxygen. And for it to be done in this manner, it needs to be stored at minus 150 to minus 170 degrees centigrade at the pressure of 5 to 10 bars. Now let's talk about oxygen cylinder. They are made of molybdenum steel, and gaseous oxygen is compressed to about 137 bar in a cylinder. The cylinders are color-coded. Different countries with their color code. In Nigeria, we use black cylinder with white shoulder. We have the size A down to size G cylinders. Size E cylinder, which we usually attach to an anesthesia machine, contain about 80 liters of oxygen. The size J has about 6,800 liters of oxygen, and this is the one we use as in our oxygen banks connected through the manifolds.
If I push something,
the gas pipeline
simply
connected and distributed around the hospital in order to facilitate the distribution of oxygen, either from the bank or from oxygen plants to get to the end users. This copper alloy pipeline is preferred because it's static and prevent degradation of gaseous oxygen that runs through it. And this is pressurized at the level of 4.1 bar.
For me, myself,
this is a picture helping us to understand what cylinders look like, different version of them. And this is what the insulated tank looks like, containing the liquid oxygen, which can actually be distributed through the small tanks and small oxygen cylinders like through these J cylinders and through the pipeline to get to the end users. There's also another gadget we refer to as oxygen concentrator. This has actually made home medical oxygen delivery very, very simple. Yes, it can also be used in the hospital. And it was invented in 1970, and over years it's been modified and made portable. Oxygen concentrator actually takes in air and removes nitrogen, leaving an oxygen-enriched gas for use for the end users. How does it do that? It uses two different technology. One is pressure swing absorption technology, or it can also use nitrogen separation membrane technology. And as a result of that, it can concentrate as much as 90% of oxygen, which can be delivered at the rate of 5 to 10 liters per minute. Now, this is a conventional oxygen concentrator, and on the right-hand side is a modern oxygen concentrator. It's now portable, battery adapted, so the patient can move around with it in his or her handbag while receiving the oxygen. Now, let's talk about the physiology of oxygen. Having been able to understand the properties of oxygen, the history of oxygen, and also how oxygen is produced. Oxygen cascade simply help us to understand the series of steps of partial pressure of oxygen from atmospheric air to the mitochondria in cell. Remember that it's in the mitochondria that this oxygen will be utilized. The blood serves like a conduit to transport this oxygen down to the mitochondria, where it will be used for aerobic respiration to release energy to the tissues and cells. Now, the physiology of oxygen transport has actually been made possible because of these two scientists, Adolf Fick and Paul Betts. They actually greatly advanced the understanding of basic oxygen physiology by describing oxygen tension in terms of units of partial pressure. They also use this unit to describe the difference in oxygenation between the arterial blood and venous blood, relating the difference to tissue consumption of oxygen and cardiac output. They were able to help us to understand that at high tension, that oxygen can also become somehow dangerous to the tissues, like central nervous tissue. Now, if you look at the table, you find out that the atmospheric air it flows at the pressure of 160 millimeters of mercury. By the time it gets to the trachea, it gets humidified and it drops to 150 millimeters of mercury. At the arterial blood, this becomes 100 millimeters of mercury. At the mitochondria, it drops to 7.5 to 40 millimeters of mercury. But by the time it gets to the vein, it remains 40 millimeters of mercury. How will it be transported? Like as mentioned earlier briefly, it goes through the blood. If the oxygen is in the arterial blood, it has to be transported to the tissue. By what means? It either combines with hemoglobin in the red cell in about more than 98% of the situation, or it can dissolve in the plasma in about less than 2% of the situation. Take a look at the diagram. You will notice that it can combine with hemoglobin or it can get dissolved in the plasma of the arterial blood. Nearly 70 times more oxygen can be transported by hemoglobin than dissolved in plasma. But there are 4 factors that can influence that. One is ventilation perfusion mismatch, diffusion defects, and cardiac arrhythmia. The body requires about 250 mL of oxygen per minute. The amount of oxygen in the blood is actually determined by the oxygen carrying capacity, the serum hemoglobin level, the percentage of this hemoglobin saturated with oxygen, the cardiac output, the amount of oxygen dissolved. Now let's look at oxygen content, which simply means the sum of oxygen that bounded to the hemoglobin as well as the sum in the plasma. We'll do some arithmetic calculation. How we'll be able to determine what the blood contains. Now, we use an equation. If we are working on the hemoglobin oxygen contents, we use 1.34 times hemoglobin concentration and then times this arterial saturation of oxygen, where 1.34 is oxygen binding capacity of hemoglobin, and this is also referred to as softness constant. If we're using hemoglobin level of 15 gram per dl and oxygen saturation of 98%, when we work it out, we'll be able to arrive at 197 mils per liter of blood. However, some percentage of hemoglobin is not really available for oxygen. It can either be combined with methemoglobin or carboxyhemoglobin. Thus, the total binding capacity of hemoglobin to oxygen is actually reduced. And this can be higher in patients that smokes. What about the plasma contents? If we also apply the same principle, but this time around, we're looking at the solubility coefficients of this plasma, realizing that at normal body temperature, 0.03 ml of oxygen will dissolve in 1 liter of plasma when the partial pressure is 1 millimeters of mercury. And if we take into the consideration that the arterial blood, the partial pressure is about up to 100 millimeters of mercury, we can work it out. And this will lead us to having about 3 mils of oxygen per liter of blood. Then if we add it with the 197 mils we got from the hemoglobin, that gives us oxygen content of 200 mil per liter. Of blood. Now, let's also look at the oxygen content we got, 200 mils per liter. Now, if we take into consideration the cardiac output of the patients, assuming we're using 5 liters as the cardiac output, if we times it with the 200 mils, that will now give us approximately 1,000 mil of oxygen per minute. And remember, the resting cell requires 250 mils, so we'll have lots of reserve to play around with in case of period where there is need period of higher demand. Now, we've been able to understand the contents of arterial blood. Let's take a look at the venous oxygen contents. Now, if we are working on venous oxygen content, we're still going to apply the same principle. Now, but however, in terms of the plasma contents, remember that the venous blood, the partial pressure is 40 millimeters of mercury. And if we work out the hemoglobin, in venous blood, the oxygen saturation is about 73 to 75%. If we're using 73%, we'll be able to realize that we'll have about 147 mils per liter. And we will add it up with the 3 mils, which we are going to derive from the venous 0.8. We will add it to 12 mils, which we are going to derive from the venous blood. That brings us to about 148 mils, approximately 150 mils per liter of oxygen is available in the venous blood. And if we take into consideration the cardiac output, looking at the table, realizing that most of the blood is available in the reservoir, in the venous circulation, we have about 3.7 liters of blood, and we have about 1.25 liters of blood in the arterial circulation, and that drops it down. That helps us to understand that venous blood will contain about 200, arterial blood will contain about 250 mils, while the venous blood will contain about 550 mils. That is, if we are using if we're using the partial pressure of arterial blood of 90 millimeters of mercury, and we're using partial pressure of venous blood of 40 millimeters of mercury, we'll be able to arrive at that. Now, some physiological data need to be given some consideration. We need to understand that oxygen content of arterial of air is about 21%, and down to the alveoli we have about 14%. The partial pressure of oxygen in atmosphere is 160 millimeters of mercury, whereas the arterial blood has about 100 millimeters of mercury. And 100 mils of blood contains 0.3 mils of oxygen in dissolved states. Each gram of hemoglobin can bind to 1.34 mils of oxygen. Remember our Hoffman's constant. Let's take a look at oxygen dissociation curve. This actually reveals the amounts of hemoglobin saturation at different partial pressure of oxygen. So that means partial pressure is the major influence in how the hemoglobin is able to get saturated with oxygen. This relationship is actually direct, but it's not linear. Now, looking at the diagram, you'll be able to understand that the hemoglobin never gets fully saturated to 100%. Remember that some of the hemoglobin binds to carboxyl hemoglobin, some binds to methemoglobin. Okay, so we rarely have up to 100% binding capacity. And if you look at the graph, you realize that at 100 millimeters of mercury, it will be able to achieve 98% saturation. At 40 millimeters of mercury, which is in the venous blood, you'll be able to achieve 75% saturation. So in the lung, the partial pressure is approximately 100 millimeters of mercury. At this, the hemoglobin has affinity to oxygen, high affinity to oxygen, so about 98% saturated. Whereas in the tissue, which is the end organs, you have a partial pressure of 40 millimeters of mercury, just as we described from the graph. And this can give you about 75% saturation. So which means, because of the lower affinity, some of the oxygen gets released to the tissue easily. Now, we need to note that at high elevation, the partial pressure is 80 millimeters of mercury. And with this, we can get about 95% saturation. At the sea level, that's where we can get 100 millimeters of mercury partial pressure and 98% saturation. So even though the partial pressure differs by 20 millimeters of mercury at higher elevation, there is almost no difference in the hemoglobin saturation. This graph helps us to understand that what we just explained. The 20 millimeters of mercury doesn't really cause so much change, but with lower partial pressure, there's usually a higher rise in oxygen binding capacity to the hemoglobin, or affinity to the hemoglobin. Now, some factors can actually affect what we just described. Looking at the graphs, it can move to the left or it can move to the right. There are some factors that can make it to tilt towards the left side, like decreased temperature, hypothermia, or decreased 2,3-diphosphate glycerides, decreased hydrogen ion. Whereas factors like increased temperature, 2,3-diphosphate glycerate, and increased hydrogen ion can make it to tilt to the right. This is what we've described from the graph. Now, having been able to understand all these factors and these principles, let's look at oxygen therapy. Oxygen therapy actually tells us that some patients actually will require oxygen at pressure higher than the ambient air pressure for the purpose of treatments. Remember that at concentration higher than the ambient air concentration. Remember that ambient air contains 21% oxygen. So the main goal of oxygen therapy is actually to treat or prevent hypoxemia, thereby preventing tissue hypoxia, which may result in tissue injury or even cell death. What is hypoxia? It simply means oxygen deficiency at the tissue level, whereas hypoxemia helps us to understand that there is low oxygen concentration in the blood. Hypoxemia can actually lead to hypoxia if unresolved. There are 4 types of hypoxia. One is hypoxic hypoxia. In hypoxic hypoxia, the partial pressure of arterial blood is reduced. The partial pressure of oxygen in arterial blood is actually reduced. And this could be due to hypoventilation, deficient mismatch, or it could be due to someone who lives at high altitude or somebody who inclined to the high altitude. Anemic hypoxia results from low hemoglobin. So the arterial partial pressure of oxygen is normal. In stagnant hypoxia, or it can also be referred to as ischemic hypoxia, the blood flow to the tissue is so low
Sorry, we've lost your audio. There seems to be an issue with network on the side of Dr. Nnaji. Please incite our patient.
Okay. Dr. Nnaji, can you please start sharing your screen?
Okay, ma'am.
Thank you. We are very sorry, please, for this speech. Kindly bear with us. Thank you.
I can go ahead, ma. Dr.
Yes,
Deneko.
please.
Please go on. Please go on.
All right, thank you so much.
Yeah.
So there are 4 different types of hypoxia, like I was mentioned earlier. The hypoxic hypoxia, the anemic hypoxia, and we also have the stagnant hypoxia. So in stagnant hypoxia, blood flow to the tissue is so low such that the oxygen is not delivered to the tissue despite the normal oxygen tension and the normal hemoglobin concentration. This we can find in some patients with cardiac failure, or those who have reduced cardiac output, or where there is interruption of local blood flow. We also have the histotoxic hypoxia. In this scenario, the amount of oxygen delivered to the tissue is actually adequate, But because of the action of a toxic agent, the tissue cells cannot utilize this supplied oxygen. So this we can find in patients with cyanide poisoning or carbon monoxide poisoning. Now, are there some indications for anaphylaxis, patient with pulmonary embolism? We also have some patients who will require oxygen because of their chronic medical illness, like those with chronic obstructive pulmonary disease. And also have some surgical indication. Yes, as an anesthetist, we never serve anesthesia drugs. Patients tend to have some receipt, as well as those with post-operative shivering. To give patients oxygen, there are some preparations you really need to make. One, we need to actually clinically observe our patient and establish that these patients will actually need oxygen therapy. So we must evaluate patients. And thereafter, with all the indications showing that patient saturation is on the low side and we require oxygen therapy, we also need to understand what is happening at the tissue level by doing arterial blood gas analysis, which will help us to establish that. We obtain consent from patients, which we rarely do in our environment. We need to obtain consent before managing a patient with oxygen. And oxygen must be prescribed. Gone are the days of, nurse, please put this patient on oxygen. No, we need to prescribe what we want to give. Do you want to give 2 liters with nasal catheter or want to give with rebreather mask or non-rebreather mask? It has to be well established and documented. And how long we want to give this oxygen therapy. Thereafter, when we commence that, we also need to continue monitor the patient, checking the pulse of arterial saturation, and also checking the arterial blood gas, doing arterial blood gas analysis to know whether we've been able to correct what the deficit we actually notice before commencing the oxygen therapy. Now, we usually start with 100% oxygen, although depending on the particular device we are using to administer oxygen. But the target is to go as low as less than 0.5 fractional inspired concentration of oxygen when we are doing that to minimize oxygen toxicity. If we are managing patients that regular patient without that doesn't have chronic obstructive pulmonary disease, the target is to keep the saturation between 94 to 98%. And if the patient, our index patient has COPD, the target is to put the saturation between 88 to 92%. Why? Because if we leave a patient on oxygen and also maintain a saturation of 100% for too long, some of them will actually, because the oxygen tension is now very high on them, they tend to have hyperoxia, and this can cause oxygen toxicity or oxygen poisoning. We need to take into consideration that the percentage of oxygen delivered, we are going to deliver to the patient will depend on the device we are going to use and also the flow rates we are going to set when managing this patient. What are those devices we can use to administer oxygen? They are grouped into different categories. We can group them based on their performance, either their fixed performance or variable performance. We can also group them based on their dependency to the patient dependent or patient independent. Now, we can also group based on the flow, how it flows. Is it low flow or high flow? And also based on degree of dependency. And on the degree of dependency, we have low dependency, medium dependency, and high dependency. Now, looking at that table, you understand that if we're using low dependency, that should actually be indicated for patients that require just supplemental oxygen to sustain life. They must be breathing spontaneously, and nasal prong and face masks, simple face masks, can actually achieve this for us. Now, if we're looking at medium dependency, they are they require supplemental oxygen because they are breathing spontaneously. However, they also need some assistance, and that's where our CPAP partners come into place. Whereas those with high dependency, their breathing is actually not reliable. So sometimes we may need to take over the breathing, and this we usually do in the ICU. And that's where our non-invasive positive pressure ventilation or invasive positive pressure ventilation comes into play. Now, this picture helps us to understand how the NASA cannula works and how it's connected in patients. It was modified by Wilfred Jones in 1940% of oxygen. So for a patient, flow rate should be at 4 liters per minute. It is comfortable and well tolerated by the patient, of which, while they are receiving the therapy, they can also eat and drink if they are on NASA cannula. Now, when we tend to go at the flow rate of greater than 6 liters per minute, the flow becomes moved from laminar and becomes turbulent. And this can actually start infecting the patient, cause some dryness. And in some patients, it's been documented that some of them can have dryness of the nasal passage or even possibly have nosebleed. This we can prevent by giving them humidified oxygen. The high flow nasal cannula is another modification of the regular or simple nasal cannula. This has actually gained so much ground with the management of COVID patients. How do we use it? It was introduced in 1999, initially for pediatric patients, but it has gained lots of ground by being modified to help us to deliver humidified mixture of air and oxygen at a particular temperature, preferably body temperature. Now, the flow rate goes from 30 liters to 60 liters per minute. We can even go as high as 120 liters per minute. It is useful for those patients who are breathing spontaneously. High flow nasal cannula also allow patients to continue to talk or even possibly eat or drink while receiving such therapy. We also have the oxygen tent, as you can see from the diagram. Most of the time, pediatric patients benefit more on this. It was invented by Leonard Hill in 1920 and later was modified by Alvan Barak in 1925. This actually can be used for patients that require supplemental oxygen. The precaution in using oxygen tents is that we must minimize how often we open the tent so that the oxygen doesn't leak out. The aim is now defeated, and sometimes it can even enrich the room with oxygen, exposing the patient to the hazard of fire outbreak as a result of enriched atmospheric with oxygen. We also have this device has gained lots of ground in its utilization in babies that are breathing spontaneously. It can also be used in adult patients. It has also been used for undersea and hyperbaric medicine centers in order to manage patients with low oxygen tension. And the benefit of it is that after use, it can also be cleaned and reused for a subsequent period. The rebreather or simple face mask, also referred to as Hodgson face mask, was invented in 1906. It is made of clear plastic and it can deliver 40 to 60% of oxygen. So most of the time we use it for short-term oxygen therapy. We usually start from 5 liters per minute. We can go as high as 15 liters per minute, but 8 liters per minute is more practical to our patients. The non-rebreather face mask is an advanced form of the simple face mask I just mentioned. This is actually indicated if we need to give FiO2 of greater than 0.4 to our patients. and it delivers as high as up to 90% of oxygen based on the flow we're using, especially when we're using 15 liters per minute. The flow ranges between 12 to 15 liters per minute, and it helps to watch the patient with high concentration of oxygen, in such a way that some with low tension of oxygen can actually get sustained or managed with this device. And if most of the time we use it for acutely ill patients, not those that are mildly hypoxic, rather those who are acutely ill, and we can use it to manage them. But the problem with using non-rebreather face mask is that if not properly used, we can run the risk of having patients who are retaining carbon dioxide during the therapy. The Venturi oxygen mask is another device which is indicated if we want to give precise concentration of oxygen. Flow rate is about 2 to 14 liters, and it can deliver FiO2 of 0.24 to 0.6 to our patients. Now, the flow rates can actually help in determine the actual rates flow rate patient can actually have at the end of the day. But remember that it's indicated for patients that require precise concentration of oxygen, like in patients with chronic obstructive pulmonary disease that we don't want to wash up all the carbon dioxide. Now, it functions based on effects and Venturi principle. Now, we're talking about Bernoulli effects. It simply helps us to understand that when a fluid flows through a constriction, which is based on the design of the Venturi, that it gains kinetic energy, losing potential energy with drop in pressure. And as a result of this drop in pressure, that's where the Venturi principle comes in. It tends to entrain some streams of air into it, thereby giving the precise concentration and increasing the flow rate that comes into the patients. Now, this is like a pictorial explanation of what we've explained. As the gas moves through here, when the pressure drops, air is entrained into the device, thereby enriching, delivering the precise concentration. So if we want to give patient using the device that can give 28%, what it means that we need to set it at 4 liters per minute. And the eventual flow rate automatically becomes 45 liters per minute. So 6 liters per minute, it is 8 liters per minute. The same. We can also manage such patients using non-invasive ventilation, the CPAP or BiPAP. These are patients that are breathing spontaneously, but somehow they also require some assistance, either because like obstructive sleep apnea and all the rest of them. That's where the CPAP machine, it tends to deliver and maintain positive pressure. BiPAP gives 2 different levels of respiratory phase. So, and those with atelectasis can actually benefit from this device. Using bag mask ventilation, especially when we are resuscitating some patients in our ICU or in the theater, we can actually give them oxygen through this. The bag mask ventilation actually has a self-inflating bag, which is attached to a non-rebreathing valve and then to a face mask that conforms to the patient facial appearance, so that we'll be able to maintain a tight seal to deliver this oxygen. For us to be successful, we must have a patent airway, adequate mask seal, and proper ventilation technique, while we are together with a PEEP valve as needed to improve oxygenation. Oxygen is always attached through oxygen tubing to the bag mask, to the amber bag. Another way, which is regularly done in our ICU, which is the invasive method, is either to intubate the patient and use mechanical ventilation in order to ventilate this patient. So when we are mechanically ventilating this patient using our machine, it helps to give us some level of control of the flow and also the volume and percentage of fractional inspired oxygen that will be getting to the patient. We can also regulate the rate at which the patient can breathe. That's the benefit of this. And because of that, we use this mainly in the ICU and in the theater. There are also some complications associated with oxygen therapy. When we are giving high concentration of oxygen at level 70 to 100% for more than 48 hours, it can damage the alveolar membrane, thereby causing some toxicity. And this can affect different organ or different system. When central nervous system is affected, patient can even have a tonic-clonic convulsion or amnesia. And when the pulmonary system is actually affected, patient can be tilted into having ARDS. And it can also affect the eye, causing some ocular damages. It can also affect the ear. Now, in conclusion, oxygen is actually transported in the blood, mostly bound to hemoglobin and also dissolved in plasma. And the plasma aspect is where hyperbaric oxygen comes into play. Sometimes if the hemoglobin is not so much adequate and we want to make the use of the plasma, that means we need to give patient hyperbaric oxygen so that much of it, since the higher the baricity, more will be able to, the higher the tension, more will be able to dissolve in the plasma to enrich or deliver oxygen to the patient. However, some factors can affect how this oxygen can be utilized by tissue, whether it can be made readily available to the tissue based on the tension or the pH of the blood, as well as temperature of the patient and the level of 2,3-diphosphoglycerides. Oxygen toxicity can actually occur when we are managing a patient with high concentration of oxygen, especially more than 70% oxygen, and it can affect different organs of the body. So once we have been able to achieve adequate saturation, the target is to step down as low as less than 0.5 FiO2 when we are managing our patients. These are my references for this presentation. I want to thank you all for listening to this lecture.
So thank you very much, Dr. Chima Nnaji, for the beautifully presented lecture. He has been speaking with us for the past 40 minutes or so on oxygen transport. And he took us through the chemistry of oxygen, history, production, oxygen cascade, and then he talked about oxygen flush before going to hypoxia and oxygen therapy, which is very critical in our practice as anesthesia and critical care provider. The next speaker we have in the line with is Dr. Job Otokwala. He's going to be talking to us on scoring system in the ICU. Dr. Job Otokwala is a fellow of West African College of Surgeons, and he is a senior lecturer and consultant anaesthetist with University of Port Harcourt and University of Port Harcourt Teaching Hospital. He had subspecialty training in cardiothoracic anesthesia and critical care. He is the lead anesthetist for the COVID team at the University of Port Harcourt Teaching Hospital. And he's also currently the presently the vice president of Intensive and Critical Care Society of Nigeria. He's a former vice president of NSA. He's served as a member of accreditation panel visit the West African College of Surgeons in time past. and is the present head of anesthesia and intensive care at the University of Port Harcourt Teaching Hospital. So, Dr. Tokwala, we are glad to have you on board, and we want you to take your lecture now. You have 40 minutes to speak with us. Just a reminder, for all who are linked to this lecture, kindly keep your microphone muted. If you have questions, comments, clarifications, you can just put them on the chat box. We'll consider them at the end of the lecture. And for those who may want to make a verbal comment, you should use the hand raise icon at the end of the lecture, but keep your mic muted until you are recognized. So I appreciate all of you for compliance. We'll go to the lecture now. Thank you. So, Dr. Tokwala, you have the floor.
Thank you very senior colleagues and colleagues.
Please, maybe your volume can go a little higher.
Is it okay now?
Yeah, it's better.
Okay. So we're discussing scoring systems in the intensive care unit. What it implies is that I'm limiting the discourse to the use of scoring systems only in the intensive care unit, so I don't get me wrong. The outline is simple: disclosures, key objectives, introduction, classification, clinical importance, validation summary, and then we'll wrap it up. It's very clear to everyone that scoring system is a very voluminous topic in critical care, and critical care is the contemporary critical care is an evolving entity with lots and lots of changes every day. So what I have tried to do is to abridge discussion. Actually, we look through the references. We have some basic tools to work with to read the topic and explain it better. I don't have any disclosures. One of the key things to take away from this discussion is, one, to describe the various types of commonly used scoring systems in intensive care units. And then we'll try to explain the clinical relevance and utility and evaluate some validations and limitations of the readily used and available scoring systems. Let's look at this static for us, and I have a couple that I didn't document here. We have a 60-year-old male patient who has cirrhosis of the liver and portal hypertension, who is admitted to the intensive care unit with pneumonia, the community-acquired, hospital-acquired, whatever it is. And then he developed septic shock and became encephalopathic and unknown. The family will want to know, assuming this guy has his daughter, his son, who is a medical student, and is asking you as an anesthetist, who is to manage this further, and ask, please, what are the chances of survival? Can a scoring system be used to predict the chances of survival of this patient who is presenting this scenario? I also have a case that I didn't present it here of an eclamptic 35-year-old lady who had AKI, had intractable bad bleeding, dyspnea, was febrile, conscious DCS of 3/15. And then the intensivist is writing a couple of investigations for the patient to do, has massively intractable bad bleeding. I'm writing lots and lots of investigations. What are the chances of survival of this patient? Robert Harding once said that in God we trust, all others must bring data. And what it emphasizes is the importance of data, in the management of the critically ill patients. Data is everything. Data is extremely important. The goal of intensive care basically is to provide the highest quality treatments that achieves the best outcome. That was the reason why Civita in 1973, when he was trying to actually define the appropriate patients that should come to the intensive care unit, said that it is one who couldn't survive without intensive care. but one who actually does survive giving such care. That tells you the expectation or what's expected of patients who present in intensive care unit. We all know how complex the case scenarios are that present to intensive care units. So the act of preventing, detecting, and managing such patients is a very, very complex one. If you walk into a typical intensive care unit, look at the noise level, the quality of activities going on. Several activities, you look at a particular patient, you see a lot of monitors, a lot of tubes, a lot of parameters being checked. That tells us how complex the management is, and lots of medications because of these patients. The patient population is basically heterogeneous. There are a lot of, there's one is coming in a mixed ICU, medical, surgical, in a mixed picture, you have this heterogeneous population. And these populations, patients who actually present with several risk factors, or they come in with some factors that you have to identify, like their physiological reserves. What is the physiological reserve of this patient who is presenting with maybe acute pancreatitis, or a surgical patient? What was the reserve before the patient became ill? That's what chronic health status means. The physiological reserve prior to the onset of illness. And then the ever-changing physiological variables. In 1 second, the temperature is 39, the next second is 40, the next is dropped to 37 or 35. The mean arterial pressure keeps fluctuating, and this is kind of scenario you get in intensive care. That's why they say the populations are basically heterogeneous with the ongoing primary illness that presents. So what does this thing mean, scoring system? To make it very simple, a scoring system is basically a tool, is an objective tool, a measurable tool based on data that you can use to evaluate disease severity and then predict an outcome. It's like a typical village woman in the village who looks at a girl who is vomiting, looking a little bit. I'm sorry using this for women, don't feel bad, but I'm taking it from the traditional perspective. An older person can just look at someone and say, I see this person is likely to be pregnant. That could be subjective. But is using scoring systems to do care, think about the objective way of evaluating disease severity and then predict outcome. I can look at the patient and say, the patient is likely to survive, or the patient is unlikely to survive, likely to die. Or this disease is very severe. Something is got to be done about it. And the case scenario I gave about the eclamptic who presented with massive intraocular bleeds, AKI, and fever and all of that. And then the nephrologist will say, don't worry, I will do maybe the range creatinine level of 500 micrograms per liter. And the nephrologist is saying, okay, I will do, and severe metabolic acidosis, I will do dialysis in 3 days' time. And the patient dies in 3 days' time. Before even the third day, the patient is dead. It shows there was no objective method of assessing disease severity. So somebody just subjectively look at it and say, okay, don't worry, you're not too bad. That is not what scoring systems do. So when we look at the patient to predict outcome, the outcome of any patient who walks in could be the length of stay. Some patients could stay within a short period. Some patients could stay much longer. Outcome could be a mortality. One of the best measurable outcomes is mortality. It's really like single binary unit. Somebody is you're alive or you're dead. If you're dead, it's not easier. But contemporary critical care management, you look at the length of stay. And some patients are admitted and they are discharged and they are readmitted. So some of these are factors we look at as outcome. What the length of stay of this patient? How long is it going to stay? And then what about the mortality? What about the readmission? And the quality of life of this patient? So what scoring systems actually do? One, all this, and then provide an objective measure of ICU performance. To do the ICU performance and then compares intensive care units, one intensive care unit to the other. I said there are tools to allow objective assessments of the clinical status of the patient, and it mirrors the probability of mortality and also help to improve clinical decisions and identify patients with unexpected outcomes. When you look at the particular patient and look at the score, and you said you predict this, sometimes it could be beyond that. And also provides an avenue for cost analysis. And it has also been found to be very useful to allow objective assessments of the clinical state of the patient. And it mirrors the probability of mortality and also help to improve clinical. There are characteristics of an ideal scoring system. One, the variable must be measurable. All that we're discussing from the beginning of this discussion is that whatever data you pick should be measurable. The high degree of discrimination differentiates whether the patient is alive or dead, and then satisfactory calibration will look at the index patient from where most of these scores are generated, and you're comparing it to what you're getting. And then it should be applied to all patient populations. Some studies are done in the UK. The UK patient may not be the same as the patients you find in Nigeria or the patients you find in some low resource settings. And then you're able to predict the length of stay. Length of hospital stay is quite important in contemporary scoring systems. They should be able to predict the length of stay and the quality of life outside the ICU. What are the components of the tools? Scoring systems are basically tools. What are they? Patient data, physiological variables, heart rates, blood pressure, saturation, EF ratios, and all that. These are all the variables that we refer to. And laboratory data. All these must be weighted. When you adjoin a weight, a point to these variables, if the mean pressure is 60 or less than 60, I attach a weight of 5 or 3 or 2. That's what it means. And the laboratory data, you attach a weight, a point to data. And the final scores are very collated, and the final score actually relates with the degree of severity. So if a score is 30, it shows that it's a very severe one. And then the person who has a very high, score, it's unlikely to live. So that would stimulate you to do much more to keep the patient alive. And then scoring system basically use high-tech statistics to create the outcome, the outcome prediction models. And these scores are extremely useful to predict outcomes in groups of patients. Allow to obtain some individuals. So another part is that user-friendly, accessible, must be feasible, and then be cost-effective. In developing a scoring system, because when I discuss scoring system, it's not like a question of we're just picking a technology that is done outside. Somebody develops it in the UK. Some Nigerians have had to develop their scoring system, with some colleagues also developed one of the sepsis scoring system, which even though it has some flaws, but some persons within are able to develop this. And then if you go further, we're also seeing some adaptation of the normal standard scoring systems that can be done yet in this country. So in developing a scoring system, you must choose an outcome variable. I've discussed what the variables could be, whether it could be mortality, the length of stay, the readmission, all that. You choose one, then you select the appropriate patient population. Are you dealing with, there are some population-based scoring systems, like maybe the ABGA and all that. You can't use ABGA for an adult. So you have to select a population that is more reproducible. Somebody who does the same study somewhere outside your vicinity to reproduce what you've done. And then select a variable or a risk factor. I'll talk about the physiological variables like mean arterial blood pressure, temperature, the various changes, temperature, the loss of consciousness, and all that. And then data. All these variables provide data. And then you subject whatever you get to a highly sensitive statistical model. That's what's one of the things that Noas was actually complaining when they asked him about the Apache score that he developed in 1983, and he was saying, you look at Google, look at Amazon, they've used technology to advance the cause of business, but they felt that the use of scoring systems is actually, if you subject them to high-tech technology, have been extremely useful to Medicare. And it's to validate, compare what you are doing with whether if you said that this predictive value gives you 90%, how sensitive and how specific is it? And evaluate the utility and impact for the ICUs across the world. So what are the indications? We've talked about these things because of our discussion. You predict outcome, and then you characterize disease severity and the degree of organ dysfunction and assess resource use. So in terms of classification, how do you classify scoring systems? You can define that what we call the organ-specific or disease-specific scoring systems. There are population-specific scoring systems, like APGAR score is population-specific for pediatric cases. Then disease-specific or disease-specific, organ-specific, and then they generally use what we call the generic use scoring systems, which is actually obtained in the ICUs. So the generic ones basically assess disease severity on admission, and that can also predict the outcome. And then examples are the Apache, the SAPS, and the NPM. And then there are all that which are severity based on organ dysfunction. Somebody comes in and then the respiratory system is dysfunctional. That's apnea or apopnea or tachycardia and all that, or tachypnea and all that. So these are basically variables that we tell that a particular organ is dysfunctional. Or a combination of these, like traumatic brain injury, we use Glasgow coma scale. These are organ specific. So, and then we provide, and that one of the third aspects is the one that assesses the nursing workload use. I'm sure if you feel some documentation will tell you what are the various types of scoring systems. Don't forget we'll talk about it later, the nursing workload score. Then though for the disease and organ specific ones, we are all aware about the Glasgow coma scale for traumatic brain injury, and then the Ransom score for acute pancreatitis, the RAFEL and AKIM for AKI, the functional assessments one used for functional states, acute functional state in the ICU, and then I talk about the ABDA score for acute coronary syndrome and heart failures. We use the CALIP and then the pricing for post-operative care. This ones don't really bother us so much because it takes us a whole day to discuss the various aspects of it. What is important to us is to talk about the ones that are generally used in basic care, the generic scores. One of the earliest is basically, and then before I will discuss this now, let me quickly run through what they call the decision support scores, like the early warning scores, so that you don't bother to ask questions. They are basically tools that we actually use to triage and then communicate and implement decisions on tolerating physiological variables. This ones don't really take into cognizance the initial physiological reserve of the patient prior to the onset of illness, and they can give you a prediction that somebody whose blood arterial pressure has dropped, or maybe temperature has increased to 40, and the next minute again looks good. That doesn't give you any predictive value. That's why it's not usually used in the intensive care unit. So these are the ones that basically used in the ICUs, the acute physiological and chronic health evaluation score. There are various stereotypes of it. First designed, developed by Noas in 1983. And then you look at the time, you look at the story, I was talking about at the time when people don't make diagnoses without having any objective way of assessing the degree of severity of illnesses. When it developed, and when he did it, you see about the flaws in the design. It's actually an efficient tool to actually predict mortality and loss and length of stay in the intensive care unit. But that's what Apache generally does, predicts mortality and then assess, evaluate length of stay in the ICU. But the first that was developed, used 34 variables, that's basically cumbersome, and allocated scores to 0 to 4. This is a chart basically. If you look at all the most of the stores are charts. So I don't need to reprint all the charts in this discussion that will make the volume of discussion voluminous. So basically, we go through the references, and I'm sure Edison will submit the slide to all of us, and then we can look at the various scores. Very easy to look at the chart and see the flow of the variables and the calculations that have been made. So he used divided into three various classes: the acute physiological, the arrangements of variables, and then the age, and then the chronic evaluation. So the A, and then the chronic evaluation by A to D. A means an apparently healthy person, and the D means someone who is severely failing. If you look at the D, means someone who has a severely failing health, shows that the person will have a direct relationship to an increased mortality, and then it shows how severe the illness is. But basically, it didn't end at just designing or developing Apache. What it is also to improve by looking at it. By then, when he developed this, the computer was not involved, so it was very easy. It was very difficult for him to like do the calculations, and then it involves a lot of statistics. But Apache 2, which is widely used, very common one, actually uses 12 variables. And then these are 12 variables that are collected the first 24 hours of admission of the patient. And to score of 71. And Apache is very common as just 12 variables. And then our own Akinyemi, Sanusi, Yelade actually look at some of the variables. I mean, in places where you wouldn't. We'll talk about it for the principle of research and think about the laboratory use or parameters that are required in Apache 2, and then have to supplant the oxygen saturation to the PF ratio. But some places you may not have the privilege of having blood gas analyzer to deal with the PF ratio. So if you read Sanusi, the Yalade paper, you see the validity of like an update of Apache 2. Apache 3 was actually developed years later, several years later, and incorporates the length of stay, which is also important, one of the important outcomes that are required in evaluating patients who are. There are also Apache 4. Apache 4 will actually go 2002, 2003, and they are use a larger pool of patients, and it has a much more refined predictive value. Can predict the length of stay. The patient is likely to stay much longer, and it helps in the planning, in healthcare planning. You know, the patient is going to stay much longer, so that bed is fixed for this patient, and then turn from an active bed to a more like chronic beds. That about the simplified acute physiological score, developed in France, 1984. Like I said, these charts are easily available online, so you can actually look at the charts. Developed in France, 1984. I use 18 weighted variables with age to predict deaths in the ICU. And like the worst values, like Apache, so we use the worst values. The first one Apache presents to the ICU, what are the worst values? Look at all the physiological variables and pick what are the worst values that they calculated. The goal Oxlow actually developed this in 1984, also re-evaluated it and made some adaptations and updated SAPs in original SAPs to SAP 2. The first one used 13 weighted variables, then used 17 variables with 12 physiological variables, age, and the type of admission, whether it's like an emergency, elective admission. All these are factors that can actually increase the risk of death, or increasing the length of stay, of a patient. That actually things that can be done in a locality. Then it's how many patients who come in as emergencies, how long will they stay, and those who come in as elective, how long will they stay, and then the underlying disease process. And then SAPS 3 was developed 2005 and actually use complex statistics, which is long beyond this discussion. 20 variables are actually used, and I want to look at SAPS 3, look at the patient characteristics before the circumstances of admission, before the patient actually presents. What was this patient like? What are the circumstances surrounding this patient, and the degree of physiological event? The mortality prediction model which has 3 other serotypes, or if I call them serotypes, subtypes, because basically they are all being upgraded and updated on a regular basis. I'm sure by before the end of this decade, more scoring systems have been evaluated by various bodies who are working assiduously to improve the care of patients in the intensive care unit. So what's the mortality prediction? Some books call it mortality probability model. What it does is it assesses the probability of a patient having a mortality at hospital. When you expect patient to be discharged, what is the probability of the patient dying? That's what the mortality prediction model does. And it's based on measurements that are obtained in the first 1 hour of ICU admission. Some patients in neurology, some traumatic brain injury, some persons have actually looked at some patients who present with distress of 3 and they said they is unlikely to survive. So you can predict, you can look at the first hour of the presentation of this patient and predict, make a prediction. A prediction, I mean, that the patient is likely to survive. And then the MPM as so that was like the second one that was developed, and then the third one that look at data from admission and after the first 24 hours. These are actually being updated. They are being evaluated to see after 24 hours, what is the probability of these patients living beyond day 2, day 1, day 3, day 4. After 48 to 72 hours, when secondary effects like this for a patient who has traumatic brain injury, what is the likelihood of those surviving? So let's quickly look through the organ dysfunction scores. This describes the degree of dysfunction, the degree of failure of various organ systems. And then the first is what they call the logistic organ dysfunction system. Like I said, these are all charts that are available online. This was developed to evaluate the organ infection the first day in the ICU. The various organ systems, respiratory, and look at 12 variables in 6 organs, 12 variables in 6 organs, and there's cardiovascular system, neurology like central nervous system, the renal, the pulmonary, hepatologic, and hepatic. You look at these 6 systems, and it creates 12 variables out of all these. Look at what values in 24 hours. And then you give a weight to each, which is written from 0 to 5, to each of the physiological variables, which appear on the charts. And then you look at these variables, and then you subject them to a logistic regression analysis. If you subject them, that gives you a total score. And if for little score, you can say that the score is increased, then likelihood of death or of the organ deteriorating or having to from being dysfunctional to a failed organ or system becomes very imperative. We're aware about the multiple organ failure score. The MODs are the organ system and scoring system. So first published by Goris et al. In 1985 and quantifies basically what they do is just give a weight, give a point to each of the variables from selected organs. And how the selection is done is you can give I take
abinci da aka sa wuta da kunewa to da Allah samu ruwan Allah dauke kai to samu ruwan
I take statistics.
Sorry, somebody is distracting us.
So 7 organs are assessed by the multiple organ failure scores, and look at the cardiovascular, respiratory, renal, hepatic, hematological, and the central nervous system. That is very similar to the logistic organ dysfunction score. These are all related, and then it mirrors organ dysfunction, and now organ dysfunction can actually affect or can predict mortality. Like I said, all these are charts that are available. The one we all know, which is very common to everyone, is the SOFA score. SOFA score is an integral part. I remember one of the literature I read, a lady went to one of the authors of Apache, said she went somewhere in a rural community where there was no oxygen, but she saw Apache score as a chart on the wall of the intensive care unit. So it shows how, and she was excited, was excited that you could see her score. So SOFA score was actually developed by European Society of Intensive Care Medicine. Initially was like a sequential sepsis based, but now SOFA score can actually, it's not only directed at sepsis, separating sepsis, severity of sepsis, or predicting mortality from sepsis, but it can be used for other organ and systems dysfunctions. So it has a score of 0 to 4. The higher the score, the more severe it is, the more severe the failure. And then initially high score actually reflects increased probability of mortality. It says initially it was actually designed to look at the natural progression of individual organ failures, how the failure, like respiratory system, how the organ deteriorates over time. And it says if you look at the initial scoring system, if an initial score within the first 24 hours is very high, it shows that in the next 48 hours, it could have like a 50% mortality. SOFA score is actually very useful. It has moved from being, 6 organs actually being assessed: respiratory, cardiovascular, renal, hepatic, CNS, and the coagulation. And so one of the biggest problems we may have with the SOFA score is being able to have access to laboratory parameters within the first 24 hours. How many hospitals will give you bilirubin level, creatinine level, the platelets? Some private clinics can, but some public hospitals may not. That could be one of the drawbacks. And that is the reason why the quick SOFA score, which is like a bedside tool, a bedside tool, you can actually stay by the bedside of the patient and look at the respiratory rate, or over the phone and say, what is the rate? And then what is the change in mental status? If you understand this, it's easier to say there is a sign of deterioration or there's an impairment. And that what defines sepsis or defines any deteriorating organ and system. Like I said, so far it's not limited to sepsis. It can be used for AKI, it can be used for other diseases. And then the one that we don't often hear, we don't really seem to appreciate, the what they call the nursing or the workload assessment scoring system. The one that is very common is the therapeutic intervention scoring system, which defines, developed in 1974 and assesses the severity of illness based on what is done for the patient. Any patient that is severely ill, we have multiple saline pumps, multiple volumetric pumps, multiple. You see them on, at least if we don't have access to them in our facilities, we can see them on TV, where you see a patient having like 20 saline pumps. That's a big workload for the nurses. So if you look at the various therapeutic activities that are being done on a particular patient, it mirrors, it reflects the degree of severity of the illness. So when you look at the patient and you see, when you say a single nurse, when you run a 1:1 nurse, one patient to one nurse, and you look at the patient having several tubes, so the higher the number of tubes, the more severe the illness is. And this is one of the scores. You can look at it and said, this is a very serious one. And then it has been, initially they used 57 therapeutic activities over 24 hours, but now it has actually been reversed to what they call the therapeutic intervention scoring system 28. And then 21, and then hello, someone say something? So that is one of these. Then these are actually the scoring systems that do with the nurses. Basically, what they do, they are basically to assess the burden of work, how the value, the number of several activities on a particular patient mirrors the degree of severity of the illness, and then also reflects increased mortality. Then I mentioned about the locally adapted scoring systems. I've mentioned the one that was done by Akiyemi et al., and then the Rwandan mortality probability model. The Rwandan mortality probability model utilizes 5 variables: age, the infection, whether there's infection, there's no infection, and then the heart rates. Because we look at the issue of, so this scoring system is actually based on data that were obtained from advanced clients where they have access to everything, but you can't compare the ICU in the States to ICU in low and medium income economies. So what they did was to like adapt this for the values, the variables to our locality and see how they can predict the same thing and subject it to validity. That's basically what the Rwanda mortality probability model actually all about, and look at patients within the first 24 hours of ICU admission, look at patients who have a GCS, low GCS admission, what is the heart rate at admission, and then is there any presence of infection or age. 5 variables were actually used, and we found that actually to predict up to 85% sensitivity. What are the limitations of all that we have discussed? One, for validation, for these things, studies were done in advanced ICUs where they access, have better quality of care, better quality of assessment, and then it's difficult to extrapolate those data to your locality. And the second one is that ICU, in fact, contemporary critical care management is very dynamic. If you see what SARS, we usually talk about SARS, now they move from SARS to sepsis, and not like severe sepsis. So the variables are in a dynamic state. So that we gradual loss of discrimination, of this value to predict that person is likely to it's alive or going to not survive, not surviving, or alive or dead. Only values likely be subjected to contemporary activities, high-tech technologies, and what they call the lead time biases, where somebody presents with a disease, and when the person, when it is discovered, or when it is the screening is done, or when the patient presents with clinical presentations, when the patient clinically now presents with symptoms of the disease. So that time lag differs. Someone in the US will have fever or maybe difficulty in breathing and presents, and the diagnosis is made in a quite short time. Like somebody in a rural community who could have fever and have to wait for 1 week or 2 weeks. So that lead time bias affects one of the limitations in trying to extrapolate this cause to locality. And then these causes are subject to high-tech, technology, statistical software. Some have proprietary issues, somebody devices like what Nnaji said when he was being interviewed some years back about why a score is not like what we have on the apps we have in our phones. And he said because medical care, we don't take it very seriously. So some of these things have proprietary rights, and you have to deal with those rights first. So it's basically highly technology-based. That is why in most of ICUs, you can't see Apache scores, so SPAR score is even difficult to see because of the gross limitations. So these are some of the limitations that abound. So in conclusion, the scores you can manage critical care without having a weighted score, something the variable weighting the scores and having access to it, a measurable and objective way of assessing the degree of severity I'm able to predict. For so many reasons, the advantages are enormous. You can predict that the person is very sick. It's possible you can bring all the resources, pull all the resources together, call all the personnel that be useful to this patient to manage the patient and reduce the length of stay of this patient. So once you can weight it, when you can objectively assess the patient, it's much easier, to intervene and then get a better outcome. But if you don't assess this, it makes it quite difficult. So it helps us to assess how sick the patient is. When you know how sick the patient is, like an anaesthetist seeing someone with a short neck or has a lifestyle, or you know that this is likely to give me a difficult, access to the airway. So when you see things like that, that is something that happens in critical care. You see the degree of illness, you must have an objective way of assessing it. And then knowing when our intervening therapy is really working. It's not just having a patient that has too many tubes, and then you know that your therapy is not working, and you have to have a way of assessing it. And that's how some of these scores actually came to be, and anticipating duration of stay in the ICU, and then very cost effective. So current systems are here to stay. They have their limitations. You can adapt so many of them. The ones that are very common, that are very useful to our locality, and make our patients much more able to predict assess the degree of severity, and predict mortality. Thank you. The references are there. They're just limited references, but there are lots and lots on all these on the net. Thank you very much.
Yes, thank you so much, Dr. Tokwala. We appreciate you for this lecture. He's been talking to us for the past 40 minutes or so. He's taking us through scoring system in the intensive care unit. He gave us an introduction, tried to classify the various scoring systems that are currently in clinical use. He also shed some light on the importance of a scoring system in clinical practice. He's talked to us about validation of scoring systems, and then he's giving us a good summary, as per the use of this system in our day-to-day work. We don't have much time to spend. I just want to, I will appeal to as many as have questions. If you can, please put them on the chat box. We'll look at them and take as many as we can take before the time is exhausted. So we appreciate you once again, Dr. Jobo Tukwala. So I want us to look at the questions that we have on the chat board. Dr. Nnaji, I want to believe that you are still around with us.
I'm with you, sir.
Oh, great. Thank you so much. So I'll have a few questions. Those who want to make verbal comment, kindly indicate with hand raise icon. We will recognize you, and then you'll be instructed to unmute and make your comment or ask question or seek clarification, whichever one it may be. So I have these questions to Dr. Nnaji. I have here from one of the audience, precisely from Ali Yusuf, is asking, how can one practically assess for the various complications of oxygen therapy on a patient receiving oxygen? How can we practically assess for the various complications of oxygen therapy on a patient who is receiving oxygen? That's the first question he asked. The second question, how can one wean a patient off oxygen with reference to the various oxygen delivery devices? These are the two questions from this participant. I would like you to address them. There is another question, but before we go to that, we can just take these questions that have been asked. Thank you so much, Dr. Nnaji.
All right, thank you so much, sir. Taking the first question, assessment of patients with for oxygen toxicity. Now, the mainstay is that before you start managing a patient with oxygen, you have to assess the patient first. And when you now assess the patient, you'll be able to delineate how severe or how hypoxic patient is. Now, when you commence your therapy, the next step is actually to monitor the patient. And while you're also monitoring the patient, you also want to be sure that you're not tilting the patient into having some complications. And most of those complications can affect different aspects of the system, ranging from the central nervous system, the eye, the ear, the pulmonary system. Now, how do you assess that? Like if you have a patient that is on oxygen therapy, especially has been on FiO2 of 0.7 to 1 for more than 48 hours, the patient is at risk of having oxygen toxicity. And if the patient starts complaining of blurring of vision, you know that something is wrong. So you have to assess all the system. On daily, you have to assess the patient. If you're having blurring of vision, it means patient is beginning to develop some level of toxicity. Once you have excluded other problems that can actually lead to that in these critically ill patients that you're managing. Now, the same applies to the to the pulmonary system. You have a patient that is on oxygen and also not responding properly the way you assume patient should respond, and the patient is on high concentration of oxygen. It should give you an index suspicion that this patient is beginning to develop some level of toxicity. However, you also need to do your arterial blood gas. You put a patient on oxygen and patient is still hypoxic, it should be able to give you some index of suspicion that patient is beginning to develop some level of toxicity. About weaning a patient from oxygen delivery, still the same issue applies. Evaluating a patient, making the decision, what device you want to use to manage this patient. And the device you're going to use would also depend on, is the patient breathing spontaneously, or is it a patient that will need some form of support, like positive pressure?
Sorry, we lost your audio there. Dr. Nnaji, we lost your audio. I don't know if you can hear me clearly.
Mandatory ventilation, you move to
there seems to be network issue from Dr. Nnaji's end. We lost your audio again. Hello, Dr. Nnaji, can you hear me? Okay. We seem to have lost him. I'm sure he will join us again.
Okay, I'm back, sorry.
Okay, yeah, thank you.
Okay, fine. If a patient is on nasal cannula, then you start by dropping the flow rates. And if the patient is still saturating properly, it's time to take off the oxygen. Arterial blood gas has improved. Those are the in this need the oxygen delivery system. I've been able to answer the question. Thank you.
Thank you very much. I just want to maybe add this to it. One thing that we do routinely, particularly in ICU, is to put patients on ventilator, patients requiring ventilatory support. And for some of these patients, I can at least, I've had to attend to one in the last 24, 48, 72 hours, who develop pulmonary edema as a result of heart failure. It happens to be a non-hemoglobin SC patient. And I've had to again and again remind my residents and other caregiver that this patient is at risk of oxygen toxicity, because oftentimes, because they are trying to achieve satisfactory saturation, the FiO2 end up being put at 1, which is quite dangerous, considering the fact that he's going to be on ventilator for days. I was thinking perhaps we can shed some light, how do one monitor such a patient for toxicity so as to avoid this risk? Thank you.
Sorry, please come again. I didn't get you well.
Yeah, for the patient who is on ventilatory support, how do we protect such patients, monitor them for oxygen toxicity? Oftentimes, if the saturation is not satisfactory, the FiO2 ends up being turned very high. Not uncommon, you find the FiO2 being set at 100%. And this is a patient that will be on ventilator for days. How do we monitor such patients, from practical point of view for the benefit of our participants? I just think if you can shed a little light along that line. Thank you.
Okay, thank you, sir. For a patient who is mechanically being ventilated with FiO2 of 1, normally when we are ventilating a patient, the target is for us not to leave a patient on FiO2 of 1 for 2 patients oxygen. You target towards reducing to what the ambient air is all about. However, because we are giving oxygen therapy, we need to go above the ambient air concentration. That's what defines the oxygen therapy. Now, if we started with FiO2 of 1 and patient saturation improves, the next step, because the target, if the patient doesn't have COPD, the target is to keep the saturation between 94 and 98%. If we'll be able to get that, what the next step will be to start dropping the FiO2 to as slow as getting less than 0.5%. However, there are some patients, as you try to tail down, you find out that they start desaturating. Now, that's where different modes in your mechanical ventilator comes into play. To support such patient, you need to really evaluate the patient. If the mode you're using to ventilate the patient is not solving the problem, if you may need to adjust, if you need to move from volume control to pressure control, those are the things that need to come into place. And because of that, there is no standard or straightforward way of managing a patient on ventilator. It all depends on what you're seeing from patient assessment that can warrant how you adjust your ventilator and also your FiO2 to achieve your targets.
Thank you once again, Dr. Nnaji. I have another question here, just one more. Does increasing the dissolved oxygen content improves patient condition? That's the first part of the question. Does increasing the dissolved oxygen content improves patient's condition, and how can it be achieved? That's a question from S. Ikra. Thank you. I don't know if you got the question, Dr. Nnaji. Hello? Hello, Dr. Nnaji, are you with me? Hello? Sorry, I don't know if you got the question. Oh.
Okay, sorry, my network went off.
I'm sorry, I perceived that. I don't know if you got the question.
Come again, please.
Okay, another question. It says, does increasing the dissolved oxygen content improves patient's condition, and how can it be achieved? Did you get me? Does increasing the dissolved oxygen content improve patient's condition, and how can it be achieved? Well, that question is somehow. But I don't know if you have anything to say concerning that. Well,
sorry, sir. Sorry, my network is fluctuating. You asked if the dissolved oxygen can improve oxygenation of the patients. Now, to answer that, we need to remember that two things comes into play. One, oxygen can be transported through the hemoglobin, and oxygen can also be transported through the plasma. And for it to be transported through the plasma, the partial
so sorry, we're having a fluctuating network from Dr. Nnaji's end. So kindly bear with us, please. I don't know if I may ask Dr. Otokwala some question. I don't have any question from you from the audience, but I want to ask I thank you once again for the beautifully presented lecture. I want to ask, it appears to me, though I may not be absolutely correct, the scoring systems are not widely used in our ICU in Nigeria. I am thinking perhaps we may want to shed some light with regards to the challenges, confronting or limiting the use of wide application of scoring systems in our ICU.
I'm sure you know why they're not being used.
Yeah, for the sake of our audience, please.
I
may
just
just
mentioned
some of those limitations.
Yeah, I'm sure if we ask the audience how many persons are aware that Akiyemi, Sanusi, and Yelade actually modified the Apache score, I'm sure many people wouldn't know about it. Now we have a score that has been modified to suit our environment. Like one of the things why, let me just use the simplest SOFA score. And I mentioned it here that part of the fact that these are just charts. These are basically charts. We use Glasgow Coma scale, and we use it very well in our ICU for traumatic brain injury. So SOFA score, even the simplest as a bedside, the quick SOFA. I mean, if you go to many hospitals, this doesn't require anything. I mean, it requires you looking at the respiratory rate, which nurses can easily determine. But the reasons could be, they said, my people perish for lack of knowledge. People not understanding the value of this cause. Scoring system could actually look like one highfalutin, very gigantic project. But they are basically simple tools that some are bedside. Quick SOFA is bedside. SOFA score, some places we have difficulty of the laboratory aspects will give us some difficulties. Like I said, most public hospitals, it's quite difficult to ask for bilirubin level and get it in 1 hour. Some places, you get the result in 2 days. The patient must have died before the result comes. So the low and medium income, that is why the Rwandans actually had to modify, even though it was modified for mortality. But our target is not, mortality is not the only outcome. We look at both the severity of illness and then the length of stay. And say how can modify, like, I mean, let me just give you an example now. I am privileged to supervise an internal medicine resident who is working on AKI in the ICU. And he told me that she was going to use SOFA as the scoring system to evaluate our patients. And I said, no, why using SOFA? You should use Apache. But while reading through this lecture, that is one of the benefits I got from this lecture, and I noticed that you can actually use SOFA for even diseases that are actually beyond sepsis. It's not only for sepsis. You can use SOFA for even AKI, you can use it to evaluate other systems. So if you understand the basis and then the benefits of these scoring systems, it's easier. They are just charts. You just place it like the ABGA score is a chart. And if pediatricians use them, so we should be able to devise, I mean, if you use these scores, it's easier for us to know the limitations, and we can now adjust and make an update or adapt it to our own use. So knowledge, number one. Two, limitations of some of the scores, like the commonly used one, Apache laboratory aspect of it, and then even so far, the laboratory aspects would all run down some low and medium income economies. That is one of the things, and knowledge and knowing the value of it. If you know the value, it's easier to utilize it and knowing the importance of using it for cost analysis and all that. So if you know it, we use it. If you know it, we should use it.
Thank you so much, Dr. Tokwala, for the light you just shared on some of the limitations confronting the use of these systems in our practice, day-to-day practice. I don't know if anybody still has a contribution or a comment. There is no hand raised now. But if anybody has a contribution, a comment, or clarification, I want us to take. We have just few minutes left, less than 10 minutes precisely. But in the absence of that, on behalf of the association, Nigeria Society of Anaesthetists, I want to invite, okay, I can see Professor Elizabeth Waso, she raised her hand. Ma, you are recognized. Good evening, you're welcome. You have the floor, please. Unmute yourself.
Okay,
Thank you.
Thank you very much. Thank you, Dr. Adenekon. Thank you, Dr. Job, for the very well delivered lecture. And thank you also, the first lecturer, Dr. Nnaji. I want to comment on the use of the scoring systems that you asked for from